My topic is the hidden bug. Mr. A, 36-year-old welder from Kolkata, presented with the vomiting and loss of appetite for 5 months, fever for 4 months, loss of weight for 4 months, history of presenting illness. He was apparently well 5 months ago, after which he started developing vomiting, which was non-bilious, non-projectile, non-bloodstained. Vomiting was not relation with the food intake. It lasted for 1 month. He had a nausea that lasted for 5 months, which resulted in decreased appetite. There is no history of diarrhea, jaundice, and melena. Fever for 4 months and not associated with the chills and rigor. Had evening rise of temperature, which was above 101 degree Fahrenheit, associated with the drenching night sweat. This was associated with the unintentional loss of weight for 4 months. He lost 20 kg in 4 months. Past history, not a known case of diabetic hypertension, TB, epilepsy, asthma, and serious disorder. No history of surgery in the past. No history of blood transfusion. Personal history, normal bowel and bladder habit, normal sleep pattern, not a smoker and alcoholic. Family history, no history of tuberculosis or hematological malignancy in the family. On examination, alert, conscious, oriented to time, place, person, icterus present, no pallor, cyanosis, clubbing, lymphadenopathy, pedal edema, swelling present in the left side of tongue, 1 centimeter, pedunculated type of growth is seen. Pulse, 116 beats per minute, blood pressure 100/70 mmHg, BMI 19.6, and CVS S1 S2 had no murmur. RSVs in the left infraclavicular area, per abdomen soft, non-tender, liver was palpable 3 cm below the costal margin, non-nodular and regular, firm in consistency, spleen palpable 8 cm along the long axis, notch felt, non-tender, firm in consistency, normal bowel sound, CNS, no focal neurological deficit, no enlargement or thickened nerve, no hypoesthetic patches. So with the above mentioned complaints, he was diagnosed to have disseminated histoplasmosis with CT-guided adrenal biopsy and swelling in the left tongue shows the histoplasmosis, and he started on liposomal amphotericin B for 14 days, followed by oral itraconazole for 1 year. He was well for 20 days, after which he started developing multiple episodes of vomiting along with a fever and cough. So the differential consider him progressive histoplasmosis due to non-compliance to the medication or inadequately treated histoplasmosis. Could be itraconazole induced gastritis or adrenal insufficiency due to histoplasmosis, TB reactivation, and secondary bacterial infection. So investigation, CBC shows normal, left normal, serum electrolyte shows hypokalemia, RFT is normal, blood culture 3 samples sent, and to rule out adrenal insufficiency, 8 AM cortisol was sent, it shows normal, and the compliance to the medication was done with the itraconazole level, its targeted level is more than 1. Our patient is normal, and CD4 T cell estimation also done. In addition, CT thorax was done to look for disseminated disease. It showed interval development of the ground glass density nodule noted in the bilateral lung, predominantly in the posterior basal segment of the left lower lobe and right middle lobe. In view of new onset of lung lesion, bronchoscopy with lavage and lung biopsy was done. It shows negative for TB, tuberculosis, and fungal culture. The lung biopsy shows features of inflammation. The LJ cultures was negative. MRI brain was done to look for any CNS dissemination. MRI was not normal. Lumbar puncture and CSF analysis did not provide any yield. In order to rule out hematological dissemination, bone marrow examination was done. Fungal culture were negative. Bone marrow biopsy shows non-specific reactive changes. He was also screened for occult intra-abdominal abscess, which was negative. The blood culture report shows growth of MRSA. To look for the source of infection, we did transesophageal echocardiogram was done to look for vegetation, which was normal, and bone scan was done to look for any bone lesion suspicious of osteomyelitis, and it was normal. The probable source of infection was concluded as a bloodstream infection due to intravascular catheter for this patient. started him on linezolid for 6 weeks, and serial blood culture then shows clearance of infection, and the persistent hyperglycemia is probably due to ambrisentan-induced renal tubular injury, and it's corrected. So my topic was approach to MRSA bacteremia. So history and physical examination, we look for metastatic infection, skin and soft tissue infection, intravascular catheter bacterial infection, and bone and joint for look for back pain, for osteomyelitis, disc inflammation, for bone involvement, and protective fever and sweat, and abdominal pain for splenic infarct, renal infarct, and psoas abscess, and headache for any septic emboli. And we have to do bedside infectious disease consultation. Some studies have shows that it improve the prognostic outcome. So, and diagnostic evaluation, blood culture, and echo is more trans-esophageal echography is more superior than trans thoracic echography, and bone scan for bone involvement, and MRI brain, CT thorax and abdomen for intra-abdominal abscess and new lung infection, and PET CT. And drug against MRSA, daptomycin, dose was 8 to 10 mg per kg IV, and linezolid. The newer drugs are ritonavir, mechanism of action, inhibition of the transglycation. The dose was 1.2 gram once daily, and digicycline, mechanism of action, inhibition of bacterial protein translation. The dose was 100 mg, and dalbavancin, bactericidal, mechanism of action, disruption of the cell wall synthesis. Dose is 1 gram. So, thank you.
Thanks, Kuthala. Any questions on the floor? You should move on. We have last Sharon.